and welcome to all the cyber site participants throughout the world. Thanks for watching this, and hope we'll try to make it worth your while. We're going to talk a little bit about what I call advanced surgical techniques for vertical strabismus, and some of that will be diagnosing these conditions, then also how we surgically manage them. But as we do always here, we start with a pre-questions, and we have in our audience, we're asking people to respond. We have these devices where they can answer them. So we'll try to answer these questions in the lecture, and we'll then repeat it at the end in the post questions. So let's start with the first question. Surgical correction of A and V patterns always requires surgery on the oblique muscles. In other words, you always have to weaken the superior obliques or the inferior obliques if you have an A pattern. And we're asking people to respond to that question. And when we get the responses, we'll see what we said, what everyone said. That looks pretty good. So the answer is 14% said yes and 86% no, thinking that you don't always, the question is, can you have A or V patterns either without oblique overaction or with, if they have it, can you approach it another way? And we'll answer that question. In a 14 millimeter recession of the inferior oblique tendon, the inferior oblique tendon is attached where? Just anterior to the inferior temporal vortex vein, A. B, at the lateral insertion of the inferior rectus muscle, B, or C, at the lateral rectus muscle insertion. And we'll ask people to answer that question, where this 14 millimeter recession, where do we usually reattach the inferior oblique tendon? So most people feel we do it just anterior to the inferior temporal vortex vein. Some of them were here, heard me yesterday speak on this a little bit, or at the lateral insertion of the inferior rectus muscle. We'll answer that question, and we'll show you where it's placed in the lecture. Now, to correct a V pattern esotropia, and by V pattern we mean that the strabismus is more divergent in upgaze. Either you could have an increased exotropia in upgaze, or a less esotropia in upgaze than you do in downgaze, and that causes the V pattern. So to correct the V pattern esotropia, the medial rectus muscles may be moved more posteriorly, A, B, downward toward the apex of the V, C, superiorly toward the open V, or D, not moved at all. So can you approach a V pattern esotropia when you also have a vertical component and you'd like to correct it in a different position of gaze? So if we look at the responses that we have 50% say that you can move it downward toward the apex of the V. Some believe you can move it superiorly toward the open V. I can tell you just briefly, we'll get into it, but as a general rule, it's medials towards the apex, laterals towards the base if you're going to correct a V or an A pattern. So, so we usually do move them down because you get more effect of the recession that you do of the medial rectus muscles in the area where you have placed them. So if you have a greater degree of esotropia and downgaze and you move the muscles down, you're going to correct more of it in that position than you would in the primary gaze position. So that's how one of the approaches to a V pattern, but we'll talk about that. So our objectives in this lecture are to learn to diagnose vertical strabismus, to differentiate A from V patterns, to recognize and manage dissociated vertical deviations, or what's commonly known as DVD, or dissociated alternating hyperphorias or hypertropias, and to learn the surgical anatomy of the inferior oblique muscle, because that's going to be involved in most of these conditions that we talk about. So vertical deviations, first of all, you can have either comitant or non-comitant or incomitant deviations. Comitant means basically that the deviation is the same in all positions of gaze, or very close in all positions of gaze, where non-comitant means that it could be different in upgaze or downgaze, hence these V or A patterns which can occur. So vertical deviations are often incomitant, and they can be due to either dysfunctional overaction or underaction of the superior or inferior oblique muscles. It could be due to paresis or contraction of one of the cyclovertical muscles, or it could be due to mechanical restriction, as we see in thyroid or in trauma to the muscle. So So many things can cause this incompetence, meaning that the deviation is different depending on where you're looking or where your eyes are. So true vertical deviations, I define true as they're described according to the directional position of the non-fixating eye. So if you have you can have right hypertropia with the left eye fixating, or you can have a left hypertropia if the right eye is fixating. But they can really be the same thing. And when you have a true deviation, the reason it's a true vertical is because you have a corresponding, the two eyes correspond to each other. So if I have a right hypertropia and I'm looking with my right eye, my right eye is going to be in the primary gaze, but my left eye will then drop down and be a hypotropic. If I fixate with the left eye, and I'll cover my right to make me use the left, my right eye will go up. So in a true vertical deviation, I'll have a right hypertropia in this case with the left eye fixating, and a left hypotropia with the right eye fixating, as opposed to a dissociated vertical deviation where you don't necessarily have the hypotropia in the opposite eye, and you can have both eyes having hypertropias alternately. And that's why it's a dissociated deviation. The eyes are not functioning normally as they do together to give you the deviation. So that's important to keep in mind. And most of the deviations that you see are true verticals where there is a hypo in the other eye. But we usually define them when we measure them by which eye by the hypertropic eye, just by convention. You can do it otherwise, but when we do like the 3-step test for cyclovertical deviations, we usually define it by where the eye is higher, or the hypertropia. And I mentioned this in a talk I gave the other day, but just because you have, let's say you have a right superior oblique palsy, for example, that would normally give you a right hypertropia in the primary gaze. If for some reason that right eye is the preferred eye that the patient wants to use, they may present with a left hypotropia, even though the muscle problem is really occurring in the right eye. So just something to keep in mind. A lot of that depends on why they prefer to use one eye over the other. Could be because of the difference in disparity in the vision. One eye could see very well and the other not. So they'll confuse the issue slightly, but you just figure it out. So let's talk about primary overaction of the inferior oblique muscle. This is inferior oblique overaction that occurs without any superior oblique muscle paralysis. It develops in perhaps 2 out of 3 patients with congenital esotropia over time. Whether they've had surgery or not to correct the congenital esotropia, they may develop this. Sometimes it's not clinically significant. It doesn't require intervention, but it can show up if you look for it. And it presents as over-elevation of the adducted eye and lateral gaze with the abducting eye fixating. A true hypertropia and a hypotropia on alternate cover testing will be present. So we'll see what that kind of looks like. Here's a guy with no primary deviation, little boy, and eyes look pretty good alignment. If we then have him look to either side gaze up and to the left and up and to the right, you can certainly see that there is over elevation of each eye in the adducted position. So this is significant overaction of the inferior obliques. You can grade them differently. Some people grade them +1 to +4. Well, a lot of it's based on your own individual, what you consider to be. To me, this is probably +3 at least, with that much of an elevation. And what you use, if you're not sure, when you get them in the lateral gaze position, is you can compare the inferior limbal height, where it is in relationship to the lower lid. Now, it's not exact, but you can certainly see a lot more conjunctiva in the over-elevated eye in both cases. So this is pretty easy to diagnose that there is overaction of the inferior obliques. And management of primary overaction is usually to weaken the inferior oblique in some manner. You can recess it, which is the 14-millimeter recession, or you can do a modified lesser amount of that. You can do a disinsertion of it, just cut it loose, or you can take a piece out of it and cut it loose, which is a myectomy. Another option is anteriorization, which is anterior displacement of the inferior oblique to the lateral margin of the inferior rectus muscle insertion. And this can also be very useful in cases of DVD. In fact, many times if we have both inferior oblique overaction and dissociated vertical deviations, we will do an anteriorization, and it can solve both problems. You have to be careful with asymmetric surgery in some of the oblique procedures, especially in anteriorization. And normally they're done symmetrically unless there's a marked inferior oblique overaction because of a unilateral condition of superior oblique palsy, say. So the inferior oblique muscle, as you can see, it originates in the floor of the orbit and maxillary bone, comes out around the medially to laterally below the inferior rectus muscle, and generally inserts just below or just right behind the insertion of the lateral rectus muscle, not usually right up at the insertion, but back maybe 4 or 5 millimeters. That varies when you do a particular case. When you do lateral rectus recessions, you usually will see it if you look for it, if you go back far enough, and you can avoid it. When you do a big resection of the lateral rectus muscle, sometimes you inadvertently bring forward the inferior oblique muscle. And if you go back on a reoperation of someone who's had a resection of the lateral, many times you'll find it all the way up at the insertion of the muscle, and that malpositioning could affect it in some cases. Generally not much of a problem, though. So just important to know the anatomy of where the muscle is. As you know, it's the only muscle that doesn't originate in the orbital apex. All of the others do. It's the shortest muscle. The superior oblique, when you include its tendon, is the longest muscle. And the rest of the rectus muscles are about 40 millimeters in length. The nerve enters the rectus muscles about 2/3 of the way back from the 40 millimeter lengths, closer to the apex. But the nerve does enter the inferior oblique at the point where it passes through Tenon's capsule, and it's more anteriorly displaced. So you can actually see changes in the pupil because the pupillar motor fibers are carried in there when you operate on the inferior oblique. If you hook it and really pull it tightly, you can actually sometimes see some dilation of the pupil. It's just because it's the only muscle really that you do get involved with the being somewhat proximal to the nerve where it enters the muscle. Not commonly, but it's possible. We used to do a procedure, and some people may still do it, called a denervation extirpation, where you actually would try to locate where that neurovascular bundle is, cauterize it, cut the muscle way down here, and tuck it back inside the Tenon's capsule to give you ultimate weakening of the inferior oblique muscle. So if you don't want to do an inferior oblique recession, let's say, this is just an illustration of it where we have a hook. We've actually this is looking this is looking at a surgeon's view. You're looking down at the eye, and this would be the left eye, and you can see that this hook is actually subconjunctivally on the inferior rectus muscle. So we're looking down at the view that you get if you're operating, and that's the inferior view. You're sitting over here, and this is the inferior oblique muscle that's been hooked and had sutures placed in it. When you have inferior oblique overaction, it generally looks like this, pretty thick, wide muscle. Whereas if it's not overacting, it looks much thinner. And that's when you look for it when you're doing an infralateral rectus, will say it won't appear to be as bulky. The good thing is when you find one that looks like this, you know that that needs surgery because it's probably been the reason for the overaction, and you can differentiate that when you looked at a lot of different ones. So what you're doing here, and these slides are trying to show kind of the same thing. This is the hooked inferior rectus muscle, and this is the inferior oblique muscle, and we have sutures attached to it. We've already pre-placed our double arm suture, and on the other side there, we're actually reattaching it to the sclera. Now, in this particular case, we're attaching it just lateral to the inferior rectus insertion. So that's really more of a anteriorization than it is of a recession when it's attached in that particular position. If we want to really recess it maximally or put it back to the put it farther back, we would attach it back here along the lateral rectus, inferior rectus muscle, locate the inferior vortex vein, which is pretty far back, maybe about 10 millimeters from the insertion, and place it just anterior of the sutures, just anterior to the vortex vein where it exits the sclera. And when you do that, that's technically a 14 millimeter recession. So we never take a caliper and measure 14 millimeters. It's just been by convention determined that that's the average where it is when you put it near the vortex vein. When you reattach it for an anteriorization, as we're doing here, if you go too far anteriorly, you can actually produce a hypotropia by converting this muscle into a depressor. You do that in all of these cases when you anteriorize it, but you can grade it if you need to take advantage of that effect. You can leave it farther back from the insertion if you don't want to have that much of a correction for any hypertropia that you have. So asymmetric surgery can be a problem if you do more on one side than the other. And here you can see the muscles attached. They're just lateral to the insertion before we remove the hook from the inferior rectus muscle. So this is, there's a recession versus anteriorization. The anteriorization at the insertion, the recession back 14 millimeters, or a moderate recession could be 2 millimeters over and 3 millimeters back from the insertion of the inferior rectus muscle. And there are different reasons why you would do it depending on how much you graded the overaction to be. So there's the inferior oblique isolated again. This is trying to show you this is just this is looking at the view. Inferior rectus is down here under the conjunctiva. Here's the inferior rectus as it runs back. There's the vortex vein exiting the sclera, and those are the two sutures straddling the vortex vein just anterior to it, and that's one way of attaching the inferior oblique to the near the vortex vein. And once again, we talk about the potential for the hypertropia if you anteriorize it too much. One of the things that's also an issue is you really, whenever you reattach the inferior oblique, you want to keep it relatively close to the insertion, the lateral margin of the insertion. You don't want to displace it too laterally from there. Otherwise, it can give you other effects of actually not functioning as well as an elevator and producing more of a depressor, and it can sort of negate some of the effect that you're looking for when you do that. So we generally attach it pretty close to the lateral margin of the inferior rectus. Some people really prefer to almost bunch it up a little bit at that point rather than risk having this something called an anti-elevation syndrome, which means you sort of weakened it too much, and you can prevent you can actually prevent elevation in the eye in that position, and in adduction or lateral gaze to the other side, and it can be a bit of a problem. So dissociated vertical deviation means that neither eye refixates with an upward movement, whether adducted, abducted, or in primary gaze position. So you never get a real hypotropia in the opposite eye when you do your cover-uncover testing. All you do is when you cover in front of the eye, you'll get a hyper in the eye over elevating. You'll sort of sometimes extorts a little bit too. You can measure it with a prism and alternate cover test, but you're only really looking at the eye that you're measuring. So if I have a right dissociated vertical deviation, I'm going to hold the base down prism in front of the right eye, and I'm going to keep alternate covering, but I'm going to only watch what happens. I'm going to keep increasing the prism until I no longer see a drop down of that hypertropic eye. And when it stops moving, that's the number of the vertical deviation. Not even looking at the other eye, but simplistically to do it that way. And then you come up with a number of how much your vertical deviation is. And you can do the same for the opposite eye, because many times you'll have a vertical in that eye when you go back and forth. So that's opposed to a true deviation where you'll obviously see a hypo in the opposite eye. And usually we correct it by anteriorization of the inferior oblique or by superior rectus recession. If you need to do it in both eyes, we usually prefer the anteriorization. If you only need to do one eye, we often do the superior rectus recessions. That's because you can create a vertical if you do one anteriorization, not in the other. And there are cases, for example, where a person has a superior rectus, has a dissociated vertical deviation with a right hypertropia, where they have a strong fixation preference in their other eye because maybe this eye doesn't see as well. In those cases, you can get away with just treating the superior rectus, maybe recession on that eye that deviates up. That's the way I approach it in those asymmetric cases. So what does the DVD look like? Well, this is a guy who's straight, little boy is straight in primary gaze. If you go back and forth, he may spontaneously, or if because of your alternate cover, over elevate the left eye. So I think you can see it's not super high there, but he certainly is different from here, with both eyes are in alignment, and there the left eye is up in a left dissociated vertical deviation. Now, you can also have the combination of the two, as I mentioned earlier. And this is a patient he's ortho in the primary position. He's got a right DVD, and I say that because he has an over elevation of his left eye, even in the abducted position or in the primary position, whereas the inferior obliques overaction generally only occurs in the adducted position. So if you do your alternate cover and you see this eye go up, probably that's a DVD in this case. But he's got more than that. If we have him look to either side, he certainly also has overaction of each inferior oblique muscle. As you can see, in the adducted position, there is also elevation, and in the right and in the left eye, in the right eye and the left eye, as he goes to lateral gaze. Sorry about that. I didn't think they could track me down from New Jersey that easily, but someone's trying to get to them later. Anyway, if I was talking about the combination of that. So this is a 6-year-old that previously had a bimeter recession for congenital esotropia, and then developed these vertical findings, which became a bit of an issue. So he has a DVD, a right hypertropia in abduction and adduction and primary position. And how do you manage this? And this would be a really good case for anteriorization of the inferior obliques because of the combination of the two. You can really correct both. And when you do that, you do it just as I said. You move them just to the margin of the inferior rectus muscle lateral margin. So let's talk a little bit about it. First of all, any questions on that, on the DVDs or management so far? No. Okay, that's good. Let's talk a little bit about A and V patterns and how do you diagnose and manage these conditions. Excuse me. Let me shut this phone off. So clinical features, horizontal deviations that change in upgaze and downgaze. Shut it off once and for all. Horizontal deviations that change in upgaze and downgaze. There are incompetent subtypes of horizontal strabismus. They are. In the A patterns, the horizontal deviation is more convergent or less divergent in upgaze. In V pattern, the horizontal deviation is more convergent or less divergent in downgaze, hence the V. They can also have something called an X pattern, where that's where you have a greater deviation both in upgaze and downgaze, and it usually occurs in cases of long-standing exotropia. People that have had it for years and years. You take them in lateral gaze, and you'll see what looks like overaction of the inferior oblique. You take them in down gaze, look like overaction of the superior oblique to the opposite on both sides. And in those cases, it's really correctable by just correcting the exotropia in most cases. You don't generally get overaction of both oblique muscles, the superior and inferior oblique, in the same eye. So you don't have to address that. Usually just by correcting the large exotropia, that improves. But when you do have these A and Bs, you do have to deal with those a certain way. So a clinically significant A pattern is generally considered as 10 prism diopters or more of a difference between upgaze and downgaze of 25 degrees and downgaze. So that's at least 10. A V pattern is usually, there's they're considered more of an issue if it's greater. 15 prism diopters are more of a difference between upgaze and downgaze, and then they usually need to be addressed if you have that. You can certainly have V pattern esotropia, V pattern exotropia, A pattern esotropia, and A pattern exotropia. They can, all four types can occur. So what are the causes of A and V patterns? Well, first of all, oblique muscle dysfunction, inferior oblique overaction is associated with V patterns, and superior oblique overaction is associated with A patterns. Horizontal muscle dysfunction, you can have increased lateral rectus function in upgaze, or increased medial rectus function in downgaze, giving you a V pattern. Vertical rectus muscle dysfunction could cause it. Underaction of the superior rectus results in a V pattern, and underaction of the inferior rectus in an A pattern, because the tertiary effects of these muscles are also are diminished because the effect of adduction is reduced, so the eyes will then turn in if it's an A pattern. But by and large, it's usually related to oblique overaction, but not always. There are concerns about orbital configuration and the relationship to A and V patterns. That's true. There are upward and downward slanting palpebral fissures, which alter the vector forces. Spina bifida is a good example of this, or meningomyelocele, I'll talk about in a second. In apert and Cruzon's craniofacial dysostoses, they often have a V pattern with apparent inferior oblique overaction, but it may be from anatomic insertion variations or oblique displacement of the horizontal muscles. And what I mean by that, most of these kids with the Cruzon's disease or aperts, if you ever have to operate on them, you will find that instead of the medial rectus muscle being right in the horizontal plane, it's displaced usually superiorly, and then the superior rectus is a little bit laterally, and then the lateral is down low. So they're actually in the quadrant between where they normally would be. It's so like they insert obliquely instead of in their normal positions, and it has to do with the orbital configuration, the origin of the muscles, and then where they end up on the globe. And it's something that you have to address if you have these cases. And they often do appear to have pseudo overaction of the obliques. And they're interesting cases when you operate, because if they have a strabismus, an esotropia, for example, you have to really, most of the time what we'll do is recess the medials, but we'll put them where they're supposed to be, as opposed to leaving them in this abnormal insertional area. It can be challenging to fix some of them. Spina bifida or meningomyelocele, when I was, we have a clinic where we saw a lot of kids. We see a lot more kids with spina bifida, and now mostly called meningomyelocele. But we had the observation where we worked in the clinic with other people and the other specialists that many of these kids had similar appearances, and they often had what looked to be their palpebral fissures were slanted, so that the lateral portion was higher than the medial portion. It didn't matter with their race, with their origin. Many kids with this, if you see kids with severe meningomyelocele that have had hydrocephalus and often have had shunts placed, they have this appearance in a lot of them. And they also get V patterns, usually V patterns, sometimes A patterns of oblique muscle dysfunction, maybe related similarly to the Cruzon's disease, where they have this displacement. So this is a fellow that's got a chin down face position because he's ortho, pretty much orthophoric and upgaze. He has an esotropia in primary gaze, in the left eye, and in downgaze, perhaps the esotropia is even greater. It's hard to tell from that position. He's looking down a little bit here too, but you can see he does have an A pattern, he does have a V pattern, because the esotropia is greater in downgaze than V, more convergent. And if, as you might expect, if you have a look to either side, you'll see an overaction of his left inferior oblique and an overaction of the right inferior oblique in left gaze. So this is really pretty consistent with the findings that you'll have in V pattern exotropia. Yes.
Fine, yes. We have a question from the cyber side doctor.
Sure.
Can you get a dissociate horizontal gaze along with a DVD?
The question is from one of the cyber side participants remotely. Can you get a dissociated, not a horizontal gaze along with a DVD? You can get horizontal dissociated deviations. They're more unusual. In my experience, they're more often with exotropia. It'll be a patient when you're trying to measure their strabismus. You see they have an XT, and it seems like when you measure it, you produce it when you cover the one eye. You don't produce it as much when you cover the other. And when you do your alternate cover, you don't see movement, let's say in the right eye, but you do see the left eye go out and come back in when the cover is removed. Yes, so you can have it alone, independent of having a dissociated vertical deviation, and it can be a horizontal deviation. The cases that I've operated on for that usually had exotropia to a large degree, and I operated only on the lateral rectus muscle in the eye that had the dissociated horizontal deviation. So yes, you can. It's a very good question. So the management of this V pattern in this case is you can recess the medial rectus in each eye for the primary deviation, depending on what the measurement is. You can weaken the inferior oblique muscles, and you can also, if necessary, because if you have a large esotropian downgaze, you may want to correct that by vertically displacing the horizontal rectus muscles, as written here, one half to one full tendon width down below. If there's no minimal oblique muscle overaction, that's a preferred procedure toward the vertical gaze position where the convergence is greater. So you move them to the apex if you work on the medials. And weakening the inferior oblique can correct up to 15 to 25 prism diopters of V patterns. But I've had some where it was such a great esotropia and disparity in downgaze that I elected to both recess the inferior obliques, recess the medials, and inferior place them to help with the V pattern down below. Now, most of the time when I've only done a horizontal surgery, it's because I've had a child that had a deviation in primary. That wasn't a huge deviation, but it was much worse when he looked up or down, and it was more, there was less inferior oblique action noted, but he had often a significant face position because of it. So he's got an esotropia, which he almost can control in primary gaze, but he can't control in primary gaze, but when he tilts his head slightly down, the eyes are in alignment, and he's okay. When he looks down, they go in too much. So in those particular cases, you could recess the medials, sometimes even only one medial, and you can inferior place it if where the eyes are more convergent, where more esotropia exists, and that works pretty well in these smaller deviations, and when you don't see this large overaction of the inferior oblique muscle. So it's a good option to be able to treat some of these vertical deviations that you don't necessarily want to do the inferior oblique surgery. So again, I spoke about this earlier, but the anteriorization of the inferior oblique involves placing it just lateral to the insertion of the inferior rectus muscle and not displacing it too far laterally from it. If you keep it in that position, you're normally going to be okay as far as any of the problems that I mentioned a little bit earlier. So if you want to walk through it quickly, you can create an inferior temporal cul-de-sac fornix incision, which and one of the cases I'm going to do this afternoon, I'm not doing inferior oblique, but I'm doing the patient with 2 medials and 2 laterals are going to be doing. In the lateral muscles, I'm going to probably use the inferior fornix incision or cul-de-sac incision to show you how we do that. It's useful in certain cases. So here you're going through the Tenon's capsule or the intermuscular membrane and sizing it while you keep the eye in elevation and adduction. You then spread the inferior temporal quadrant, and you can then hook the inferior oblique as it is in that position, and you can see when you get it on the hook, if you clear the tenons around it, you can get it in a position where you can disinsert it. With the inferior oblique, I do it so I switch from doing it different ways. Sometimes I hold on to it with a forceps and just cut it off at its insertional point, because if you let it go, it doesn't go anywhere. It's the only muscle you can get away with that. It doesn't. I mean, it can get a little bit confusing in some of the tissues. So I wouldn't recommend doing that. I usually like to have it fixated somehow with the forceps, or pre-place the sutures like I do with the horizontal muscles, then disinsert it, and then you can do what you got to do with it. So we isolated it, and we're trying to we're going to disinsert it. In this case, we're holding it with a clamp and cutting it off. Now, usually when we do this picture, I will go, if I'm going to do this, I'm going to go as close as I can to the insertion of the muscle and then cut it off. For illustration purposes, we were just showing how you could clamp it and then cut it off, and then still have clamp. You can actually cut it through the, what you should do is remove the clamp, cut through the serrated area to get less bleeding. So that's one way of doing it. Then you can pass your sutures ahead of time if you like, or afterward, depending on what becomes easier to do. And then once you have it attached, you can elect where you want to put it. In this case, we did an anterior transposition of the inferior oblique and attach it just lateral to the insertion of the inferior rectus muscle. Now, I talked about the 14 millimeter recession, which means putting it straddling the vortex vein. Not the greatest picture I have of it, but it can work. And the anteriorization there. So if we look at an A pattern here, here's one that's pretty much somewhat ortho and primary. And by the way, when they're ortho and primary gaze, just because they have a V or an A pattern doesn't mean you have to do anything about it. Sometimes we leave them alone. The only time I intervene is once again if they're ortho and primary or close to ortho, but they have a significant face position because they seem to prefer that, you may need to do something in those cases to correct that deviation to allow them to use the primary position. But generally, if they don't have a deviation, they're going to be ortho and primary. They're not going to need to develop any torticollis or face position to correct it. Anyway, here's one who's ortho and primary gaze and has a small esotropia in upgaze, and in downgaze there's a large exotropia, which is really due to, in this case, you can see the left superior oblique overaction. So when you go straight down, the right eye is abducting a little bit. Actually, we're trying to look down into the right. When you do that, you can see that the left eye, instead of going in all the way over an adduction, there's so much depression effect from the superior oblique that it pulls the eye down, and you could compare the superior limbus here with there, and that'll tell you that you do have overaction of the in this case the left superior oblique muscle. And here's the same. This is a better example of it. When he looks down into the left, you certainly can see that there's overaction. This is significant 4+ overaction, and when you bring him straight down, you would expect that he's going to get a big A pattern, meaning the eyes will be much more divergent and down gaze. This is, I guess this might be another one, A pattern, exotropia, or esotropia. It can occur either way. So this is one where, I guess I moved this over the wrong way. I got fouled up here somehow. But this is down gaze, goes out, overaction of the left superior oblique, overaction of the right superior oblique, pretty much okay in up gaze to the right and left, XT down gaze. And I believe if I could slide this slide over, there's an exotropia in primary position slightly. But this is an example of an A pattern with an exotropia. You can have both. Now, the management of A patterns is a little bit trickier than the V patterns, and that's because, as I referred to yesterday, the inferior oblique is much more forgiving as far as surgery that you do on it. It's self-adjusting. When you put it where you want to put it, you usually get what you need and not much more. You don't overcorrect them. But that's not the case with the superior oblique. The superior oblique, once you cut that tendon, you have a concern about torsional problems being induced and producing even a superior oblique palsy, as I mentioned with the Brown syndrome. And especially in a case where they're pretty much ortho and primary, that's a big issue of not wanting to do too much with the superior obliques and perhaps leave them alone, because these are the ones that really get torsional. If they're binocular, and I really go hard on testing these kids with Worth 4 dot with stereo acuity, and if they're ortho and primary, they may well indeed have 99 circles of stereo that we use in 40 seconds of arc, which means they're bifoveal fixators, which means that they're really truly fully binocular. You got a problem if you just cut those superior obliques. You may end up inducing torsion, and it may be an issue that bothers them for the rest of their lives, and it's not good. So you need to do it when necessary. If I have a big A pattern, if they're not binocular, and I know they're not binocular because they have this huge primary deviation, I'm more likely to do something like that to correct it. So you can weaken the superior oblique by bilateral tenectomies, where you just kind of cut a piece of it out and let it go. Bilateral superior oblique tendon expanders. You put a retinosilicone band extender in there. I mentioned that yesterday. You can correct up to 35 to 45 prism diopters of an A pattern with these ESO shifts and downgaze, and produce an ESO shift and downgaze if you weaken the superior oblique using these techniques. Of course, you can also displace the lateral rectus muscles, half a tendon to one tendon width in the direction where the divergence is greater. So I mentioned earlier, you move the laterals towards the base of the V or the A, and the medials towards the apex of the A or the V when you do these transpositions. And again, avoid superior oblique surgery in binocular patients. And you know, that's general rule, very good rule to keep in mind. So how to remember this? You know, the direction. This is from the basic clinical science course books from the AAO. Direction of displacement of the medial rectus muscle and lateral rectus muscles in operations to treat V pattern deviations. And with the A's, the medial rectus muscles are displaced toward the apex, the laterals towards the base, and same for the for the V patterns, medials towards the apex, laterals towards the base. So this is a good thing to use when necessary. It avoids you having to do more surgery than necessary, and it can be work pretty well. In fact, I think on Friday we have a woman we're going to do here that has she's a high myope. She's got significant esotropia, and we were planning to recess the medials and at the same time I think infroplace them in her. I have to look at her chart, but we're going to do what's appropriate for her with this tendon transfer. So, what about a V pattern esotropia? Here's one that has a much greater deviation in downgaze, and once again, he didn't really have too much in the primary position, maybe a little ESO, but not much. In an upgaze, he looks pretty much ortho, but in downgaze, you can see by the pupil reflexes that he's gone into a pretty large ESO in that position. So as you might expect, once again, he has bilateral overaction of the inferior obliques, and I'm pretty sure he's one that had medial rectus recessions when he was even younger, and then over time developed this bilateral inferior oblique overaction. And in a case like this, we did have to weaken the inferior obliques on him. And then I showed you earlier a case of DVD and inferior oblique overaction, which is here after a BMR for an esotropia was left with a DVD. So it does show you that a lot of these kids that have had surgery for infantile or used to be called congenital esotropia do develop vertical deviations over time. And some are clinically significant and some are not. So parents do often ask the question, when you do the surgery, is this going to be it? Can you take care of it, you know, once and for all? And so we never really can. I say, well, our goal is to get it as straight as we can, to keep it there as long as we can. But there are always possibilities of the eye turning again or drifting again, and that we can address it, though, if necessary. And once if they've been through the surgery and they see it's a pretty decent experience for them, they're usually willing to accept that it's possible that this would happen in the future again. And, you know, just have to be honest with people and tell them what the expectations are. I mean, most don't need surgery again. I wouldn't say really infantile ESOs, but you know, some do. So here's an overaction of the right inferior oblique, again, using the inferior limbus as the guide to tell you that there's over elevation occurring, because sometimes this one has epicanthal folds, you know, and you can't even see where the medial and lateral canthus join. And sometimes when you have that, you get some things that look like overaction if they have a lower lid crease on one side. And you're not quite sure if that's what there is. But if you can really see the inferior limbus clearly, you can use that as a guide and give yourself a better idea of what you're dealing with. So you can also have, as I said, the DVD and inferior oblique overaction, anteriorization of the inferior oblique muscles for bilateral and can correct both. And the other is the superior rectus recession. There are other options you can do, which I mentioned earlier. You can also resect the inferior rectus on one eye. You do a posterior fixation suture, which means you put a suture in the muscle, belly of the muscle back, maybe toward the equator to reattach it and to fixate at that point. And you can do that on a superior rectus recession, if you a superior rectus muscle, if you have a DVD. These are other techniques that are available. So the objectives of this lecture or to learn to diagnose vertical strabismus, differentiate A from V's, recognize and manage DVD, and learn the surgical anatomy of the inferior oblique muscle. And hopefully we accomplish that. And we'll go through the questions again as the post-test option. One, surgical correction of A and V patterns always requires surgery on the oblique muscles. So we can answer that question. And we'll see what we got here. And I think that should be good. If we do that, 92% said no, it does not always require surgery on the oblique muscles. Certainly it does not, because you can transpose the muscles 1/2 tendon with up or down when necessary. And sometimes you don't have to do anything even though it's there. In a 14mm recession of the inferior oblique muscle, or inferior oblique tendon is attached where? Just anterior to the inferior temporal vortex vein. B, at the lateral insertion of the inferior rectus muscle, or C, at the lateral rectus muscle insertion itself. And our responses are coming in. And we will see what we have here. We have 83% said just anterior to the inferior temporal vortex vein, and that's where it goes. You at the 70%, you have to review this anatomy, because if you attach it at the lateral rectus, at the lateral insertion of the inferior rectus muscle, that's more of the anteriorization. That's the difference between the two. And that's good. 0% for at the lateral rectus muscle insertion. That would mean you left it there in the first place and then didn't move it. To correct the V pattern esotropia, the medial rectus muscles may be moved, A, more posteriorly, B, downward toward the apex of the V, C, superiorly toward the open V, or D, not moved at all. And we should get a good response on this one. We'll hit it again. And sure, 100% said you can move it downward toward the apex of the V. So everybody learned that lesson, and that's good, useful information. I think that we have concluded with this lecture. We've reached the final point of this, and thanks to the CyberSite audience who were able to observe this. I don't know if we have any questions coming in, or if you can do anything with that, or I guess we're done.